Hello, everyone, and welcome to the first of the Epilepsy Educational Webinars of 2024 by ILAE Africa. I am Neerja Chowdhury. I work in the WHO in Geneva headquarters in the Brain Health Unit, and I'm extremely happy to be here today with all of you, given that it is a great opportunity we have on International Epilepsy Day to begin this journey of raising awareness of epilepsy, what it is, how it can be treated, and what is needed to bring treatment to all the people who need it. Another great opportunity we have is also, let me remind you, the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders, which was endorsed in 2022 by the World Health Assembly. And in fact, the fifth strategic objective of the action plan solely refers to epilepsy, raising the public health priority of epilepsy. An important resource to do this is mhGAP, and you'll be hearing more about mhGAP today. Before we dive into today's exciting presentation, let me just go over some rules. One is that your video cameras and your microphones will be switched off throughout the webinar. Any questions that you have, please put them in the Q&A link that you'll see at the bottom of your screen, and we'll address these as we go along. There will be some announcements at the end of the webinar, and also this webinar will be recorded, and it will be available on the ILAE YouTube channel as well as on the website. When we speak about mhGAP, I think what is important to know is that these guidelines that you will hear about are new, but mhGAP has been around for at least the last 15 years. It has been used in over 100 countries and translated into more than 20 languages. Recently, WHO, just a couple of months ago, in fact, published the third update of the mhGAP guidelines. And we have today with us our esteemed speaker, Professor Charles Newton, who I have the great pleasure of working with for quite some time. Charles has been an instrumental contributor to the development of these guidelines updates, and I think it's great that he'll be sharing his experience with us and we can all learn from it. For those of you who don't know him, Charles is a pediatric neurologist by training with over 35 years of experience in conducting neurological studies in East Africa. For the last 20 years, he has conducted large-scale epidemiological studies of epilepsy in 5 countries in Africa, including Kenya, where he resides. He has been involved in examining the treatment gap and stigma associated with epilepsy and adherence to anti-seizure medications throughout Africa. He is also the Cheryl and Rees Scott Professor of Psychiatry at the Oxford University, the past chair of the Epidemiology Commission for the International League of Epilepsy, and has been working extensively on the mhGAP program, not only for the sections on epilepsy, but also for the other sections of mhGAP. So without much ado, let me hand over to Charles. Charles, the floor is yours.
Thank you very much, Neerja, and thank you very much for that introduction, and thank you for the ILAE for inviting me to talk about a subject which is close, and particularly on International Epilepsy Day today. It is a great privilege also to share the platform with Neerja, because in fact it's the WHO who've really driven the mhGAP guidelines and devised it, and I think that these are now making a indelible impression and changes within many countries across the world. I'm going to share my screen now. There we are. I hope everybody can see that. This evening I've been asked to talk to you about the 2023 updates on mhGAP, in particular with the relevance to epilepsy. I'm going to give you some background first of all, and then go into the updates that have occurred. The questions, please do put questions in the chat, and we'll get to them as we at the end of the talk. So the problem that we face with epilepsy in many low and middle income countries, and particularly in Africa, is that there's a great burden of disease. There's a significant diagnostic gap in that many people with epilepsy are not diagnosed. And then there's also a considerable therapeutic gap, which not only consists of the prescription and adherence to anti-seizure medication, but also the ancillary modalities for managing epilepsy, including psychosocial support and education, as well as some of the ancillary things such as ketogenic diets. As most of you will be aware, one of the problems that we do face within many low and middle income countries, and particularly in the most resource poor areas, is an erratic supply of anti-seizure medication that can profoundly affect individuals with epilepsy. So most of you will be aware that the global burden of disease is that for mental health and neurological and substance disorders is considerable, represents probably about 10% in terms of the disability adjusted life years, and about a quarter of all the disability of years lived with disability. In Africa, the burden is estimated to be about 22% of the slightly over 1 billion people that live in Africa at the moment. And as most of you will be aware, the risk of having a seizure in a lifetime is about 10%, and 1/3 will develop epilepsy. But this sort of belies the problem that we have in Africa in particular, and I'm going to concentrate mainly in Africa since this is the ILAE Commission for Africa, but this also applies to other resource poor areas around the world. So the incidence is very high. It's higher in Africa than any other continent, which results in an increase in prevalence, but also there's an increase in mortality. So the prevalence is not as high as the incidence would dictate. There is also spontaneous remission, which is very difficult to measure because you need large-based cohort studies, which are followed up for a long time to determine this. But what I'd like to highlight in particular is that the prevalence of epilepsy, particularly in the rural areas, is much higher than that in the urban areas. But what we don't have is that we don't have any information on the urban informal settlements in terms of the burden of disease there. And there might be special circumstances why this might occur. For example, you can imagine if somebody develops epilepsy in an urban informal settlement, they might be sent home to a rural home because of the difficulties of trying to manage epilepsy in that context and also get gainful employment. So we do have a problem in resource poor countries, is that there is an increase in the amount of people living in urban settlements. So this is data from a report of which suggested that in 2018, of the 7.5 billion people in the world, over 1 million of people were living in urban settlements, and about a quarter of these were living in Africa. And as you can see from the diagram, the proportion of people living in the urbans in Zambia, Nigeria, Kenya is considerable, with nearly half the population living in informal settlements in the urban areas. So this represents a really area which is particularly important in order to try and raise public awareness of epilepsy, but also try and reduce the diagnostic gap and improve management. So who manages epilepsy? Well, in sub-Saharan Africa, traditional health practitioners probably see more people with seizures than anybody else. The difficulty is, of course, we don't know the number of traditional health practitioners, and many of them don't actually manage the seizures because they only a proportion of them will actually take on the management of seizures. So the data of how many do manage seizures is relatively limited. But this is data from Kenya in 2020 with a population of about 53 billion. And as you can see, the main people that were in the formal healthcare system that will see people with disease conditions are the Kenyan registered community health nurses, the Kenya registered enrolled community health nurses, the registered clinical officers, and then the doctors, particularly medical officers, and the specialists, physicians, pediatricians, psychiatrists, neurologists, see a relatively small proportion. So you can see that the real people who actually see the primary epilepsy in primary healthcare are mainly community health nurses, clinical officers, and medical officers. And this represents probably about in the order of about 95% of the health care force within Kenya. And those are the people that are dealing with epilepsy on a day-to-day basis in the context of their practice. So this is what the mhGAP, which is the Mental Health Gap Action Program, was really targeted to. They are targeting these primary healthcare workers in order to try and improve the diagnosis of epilepsy and also improve the management of it. As Naja's mentioned, it was launched in 2008. The intervention guide was first published in 2010, updated in 2015, and as you've just heard, it's now been updated again this year. And so the guideline and its associated products are now used, as Naja already mentioned, in over 100 cases, 100 countries, and is available in 20 languages. So this has been a massive distribution over the last 15 to 18 years. So the guidelines are based upon a very rigorous process by which data is identified and also assessed in order to bring together these guidelines. So this is the WHO have been particularly rigorous in this in terms of developing a handbook for the guideline development, which meets the international standard for evidence-based guidelines. So normally what happens is the WHO steering group identifies priority questions and outcomes and presents them as PICO, which is population, intervention, comparison, and outcome. And they develop these PICO tables for each question, which is then developed and confirmed. This is reviewed by the guideline development group, topic expert groups, and a guideline methodologist. The systematic reviews are then conducted in order to provide evidence for the outcome identified or conducted. And this evidence is graded, is assessed according to the grade recommendations, which are the grade recommendations of assessment, development, and evaluations. And then the CDG, the Guideline Development Group, develop recommendations that are consistent not only on the certainty of the evidence, but also on the balance of the desirable and undesirable effects, the values and preferences of intended users of the intervention, the resource requirements and cost effectiveness, the health equity, quality and non-discrimination, the feasibility of the interventions, and also the human rights and social cultural accessibility. And as you can see on the right-hand side, this is a process which has gone through and takes a considerable amount of time in order to come up with the final recommendations. So the grade quality of evidence is something which many of you will be familiar with. And I'm just mentioning this briefly because I'm going to briefly refer to it and later on the talk. And that is high, we're very confident the true effect lies close to the estimated effect. Moderate, we're confidently moderately confident in the effect estimate. Then we also have low, where the effect estimate is limited, and this often is due to lack of data, and the true effect may be substantially different from the estimated effect, and the very low when we have very little confidence. In addition, there are the recommendations, and these are based upon are determined by both the audience, whether they're the people or individuals with lived experience, or the public, or the healthcare workers, which is where the main mhGAP is really targeted for or for the public policymakers. And then it's divided up into a strong recommendation and a conditional recommendation. So if I go down to the strong recommendation for healthcare workers, most individuals would receive the recommended course of action. The adherence to this recommendation, according to the guideline, could be used as a quality criteria or performance indicator. And formal decision aids are not likely to need help for individuals to make decisions consistent with their values. Conditional recommendation there would be different choices which would be appropriate for different people, and then each person might be helped to arrive at a management decision consistent with their values and preferences. So there's a much more uncertainty and leeway in this way, in the conditional recommendations. Decision aids to make decisions are consistent with their values and preferences, and clinicians would expect to spend more time with an individual when working towards such a decision. So the CGU also uses not only quantitative but qualitative evidence, and particularly from 13 country case studies, as well as the systematic reviews, which I've already mentioned. And the other thing that the WHO have developed is a evidence to decision framework in drafting these recommendations. They integrate 14, or they integrate. And this allows a structured and transparent assessment of the evidence to decision considerations. It highlights other research gaps, and including the need for evidence on the potential equity and disparity reduction associated with these inventions, and need for more evidence on views of people lived with these conditions, such as epilepsy. There's 3 steps outlined, which you can see on the panel on the right-hand side. And this again adds to the robustness of the data and of the recommendations that come forward in terms of the mhGAP guidelines. As NHGRI has already alluded to, the mhGAP provides evidence-based guidelines and tools to make progress towards achieving targets set out in the Comprehensive Mental Health Action Plan, the Intersectoral Global Action Plan for Epilepsy and Other Neurological Disorders, the Global Alcohol Action Plan, and the Global Action Plan on the Public Health Response to Dementia. So considerably important in this regard. I would also like to, before I go through the update of the recommendations, also just to emphasize that there is quite a lot of cross-cultural adaptation and translation of training materials. And these need to be translated and taken into context in which they're going to be used in the circumstances, the countries, the culture, and also the language that is used in order to make them more effective. And this is particularly important for the psychosocial and psychological interventions that are proposed. The guidelines provide details on key implementations and considerations of and research gaps for each recommendation. And again, on the panel on the right-hand side, you can see a simple algorithm which shows, which takes you through the diagnosis of epilepsy, which is within the mhGAP guidelines. So what are the updates in 2023? Well, the first one I'd like to emphasize really is that the psychological interventions are emphasized as a cornerstone for the treatment or management of people with mental, neurological, and substance abuse conditions. And I think this is particularly important for those of us who see people with epilepsy frequently, because we often forget the comorbidity associated with epilepsy. And it's often the comorbidity, for example, the behavioral problems that parents report, or the anxiety that adults report that affect their quality of life and have a profound effect on how they function within society. So I think that these updates, which have emphasized these as particularly important and particularly relevant to epilepsy. 2 drugs have been included for the treatment of epilepsy, and this is levetiracetam and lamotrigine have been included. And one of the most important recommendations is that sodium valproate is not recommended in girls or women of childbearing age. And this is because of the teratogenic effects, which are now, the evidence is overwhelming in this regard. So the actual recommendations or the actual updates are a number of specific ones that have occurred in 2023. And the first one is in adults with epilepsy, with status epilepticus. So I'm just struggling with my thing. Status epilepticus, that is seizures lasting after benzodiazepines have been given, which anti-seizure medications are associated with better clinical outcomes, that is stopping seizures with less side effects. And in adults, it is suggested that either intravenous phenytoin, intravenous phosphenotoin, intravenous levetiracetam, or intravenous phenobarbital or intravenous valproic acid should be considered with appropriate monitoring. The strength of these recommendations, according to the criteria which I've already mentioned, is conditional, and the certainty of evidence is low. This also applies, oops, my slides are not going on. Let me just try. Okay. This also applies to children as well, with the same recommendations. Here, the strength with the same drugs, and the strength of the recommendation is conditional, but the strength of evidence here is moderate as opposed to low in the adults. There are a number of justifications, and this is what is in the PDF, which you can download from the WHO website, which provides with some of the rationale behind these recommendations. So the first of all was that there was a more recent systematic review which was conducted and published in 2023. They pointed out there was low to moderate quality evidence that there was no clinically important difference between the intravenous phosphenotoin, levetiracetam, phenytoin, or sodium valproate after failure of benzodiazepines. There was low quality evidence that phenobarbital may be more effective than sodium valproate in adults with status epilepticus. There was low to moderate quality evidence that the safety profile of levetiracetam was better than phosphenotoin, particularly in terms of the cardiovascular adverse events. There was low quality evidence that phenobarbital has a high risk of respiratory depression and cardiovascular effects as compared to sodium valproate. And this is particularly important in the context of people who've been given repeated doses of benzodiazepines for the treatment of status epilepticus. What was highlighted was the speed of administration. So phosphenotoin, levetiracetam, and sodium valproate could be infused over 10 minutes, while phenobarbital and phenytoin was recommended over 20 minutes. And of course, as most of you will be aware, the essence of treating status epilepticus is the timing, trying to stop the seizures as quickly as possible. Of note was the insufficient evidence to recommend locazimide or a diazepam infusion at this time. There are other remarks which are also mentioned that. I'm just going to highlight a couple. There were advantages of levetiracetam and sodium valproate to include lesser adverse events compared to phosphenotoin. Both these drugs are broad spectrum medicines, which means that they will affect with action against a multitude of seizure types. The other thing that I would point out is that sodium valproate is associated with hepatic side effects and is contraindicated in liver disease. And it also can be, particularly in children under the age of 2, you need to be wary of it in case there's an underlying metabolic condition, which is causing the status epilepticus. Phenytoin is a difficult drug to use. It's associated with arrhythmias and hypertension. It's particularly difficult to ensure that the pharmacokinetic properties occur that you get an optimal dose in this context. But it is the most widely used and established drug for the treatment of status epilepticus around the world. There was some special note about most trials have excluded women who are pregnant, and that seizures in pregnant women can be due to eclampsia and require different treatment. And also, just to point that although sodium valproate is not recommended in women and girls of childbearing potential, the recommendation in terms of status epilepticus, because it's given for such a short period of time, is that it may be used if it's the only drug that's available in that situation. I'm struggling with my slides here. Okay. They also recommended in the guidelines the research gaps. Again, most of the research has been conducted in high-income countries. There were very little from low and middle-income countries. There were very little from older adults, and also the effect of comorbid conditions in this population group may have profound effect. Post-traumatic seizures also require special consideration and were generally not included in the studies. There was limited information on the electrographic seizures as opposed to complete resolution of clinical seizures and status epilepticus, particularly in children. And the outcome is highly dependent on etiology of the status epilepticus. So, for example, we found that in malaria, fosphenytoin was not particularly effective in this context at preventing seizures in that context. So the implementation considerations, the choice of medicine will depend upon the availability, costs, and side effects. The feasibility and affordability are major issues. So the intravenous sodium valproate and levetiracetam are not generally found in many district general hospitals throughout low and middle income countries. These drugs, intravenous levetiracetam and phosphatone, weren't on the WHO EMNL, but they are now. And then just highlighting the importance of other support that's required during status epilepticus, and that that there has been a delay in initiation and underdosing observed in the treatment of status epilepticus, which has probably contributed to a worse outcome. There's also time to get medical attention seems to be much longer in resource-poor areas, as one would expect. And there's better need for pre-hospital management because of the difficulties and the logistics of getting somebody with a seizure to a hospital in rural areas in particular. So the second update, those are on status epilepticus, is on adults and children with epilepsy, which anti-seizures medicines are effective and safe. And this is divided up into generalized onset seizures and the focal onset seizures. And as you can see, monotherapy with lamotrigine or levetiracetam or valproate acid in childbearing women or girls are the first-line treatment for generalized onset of epilepsy. For women and girls of childbearing, obviously levetiracetam or lamotrigine would be the first-line monotherapy. And if that drug if one of those drugs doesn't succeed, then another first-line monotherapy should be tried. If the problem with these drugs, lamotrigine, levetiracetam, and valproate acid, sodium valproate, is that these drugs are expensive and they're not generally available in many district hospitals and only found in specialist centers or in urban areas. And therefore, if they're not available, then either phenobarbital or phenytoin are the drugs of choice for generalized onset seizures. The strength of these recommendations was strong, and the certainty of evidence was high for these recommendations. The other thing I would just point out too is that particularly in sub-Saharan Africa, a lot of people are on antiretroviral drugs, and many of these drugs, for example, phenobarbital, phenytoin, carbamazepine, interfere with the antiretroviral drugs, and therefore there's even more reason to put people on to levetiracetam or sodium valproate. For focal onset seizures, monotherapy with lamotrigine and levetiracetam again are recommended for children and adults with epilepsy. Carbamazepine should be used if these are not available. Carbamazepine is much more widely available in many resource-poor areas. And likewise, the standard therapy, if the first monotherapy doesn't work, then try another drug as monotherapy. Lacosamide should be offered with second-line monotherapy for focal onsets if none of the first-line medicines are effective. This is an expensive drug and is not widely available within many countries. And then if the anti-seizure monotherapy is unsuccessful, people with generalized seizures or focal seizures should be referred to a specialist for further consideration of treatment options. Again, the recommendations are strong and the certainty of evidence is high. So there are a number of justifications, and these are outlined in this slide. There's really quite compelling evidence about the monotherapy and the recommendations of the monotherapy drugs, particularly in terms of levetiracetam and lamotrigine, which performs better in terms of carbamazepine in generalized seizures, as well as sodium valproate. For focal onset seizures, there's a high certainty that carbamazepine performs better than gabapentin, and it is similar to the other drugs that are being recommended, levetiracetam and lamotrigine. The general marks is that the seizure choice does depend upon the seizure semiology, and if you do have an EEG, that also sometimes helps in identifying focal onset seizures. There are a number of other drugs which can be considered as broad spectrum drugs, but these are generally not available in sub-Saharan Africa, particularly in the public domain. It is important to point out that there's no randomized controlled trials comparing these anti-seizure medicines for the treatment of epilepsy with placebo, mainly because this is unethical, and that again emphasizing the importance of avoiding sodium valproate in girls and women of childbearing age because of the teratogenic effects, and also in people with who may develop liver disease as well. There are again research gaps, as always. There seems to be there is more work needed in low middle income countries. Many of the studies didn't consider adults and children as subgroups, and also the studies on older adults was very small in the reviews that were looked at. And also, I think that what is particularly important, that in many of these studies, there was no evidence about the effects on outcomes of mortality or quality of life. So I've mentioned the implementation considerations. So the next update was really this very important one and very strong recommendation, although the evidence was very low, and that is that sodium valproate should not be used in women and children of childbearing potential, and the drugs of choice are lamotrigine and levetiracetam. And this is really a shift in the way that much of epilepsy is managed in lower middle income countries. And sodium valproate is a good drug. It's very effective. And it's particularly useful in people on antiretrovirals because it doesn't interfere with them. But because of its teratogenic effects, which are well documented, that this is now not recommended in women and girls. There was also a look at the standard breastfeeding recommendations, and the recommendations were that that people with epilepsy could continue taking the anti-seizure medication that they're on if they're on breastfeeding. There seems to be very low concentrations of anti-seizure medications within breast milk. But I think it would probably be prudent to make sure that people are not taking sodium valproate, although there's no evidence to support that. So this was the evidence was looked at and has been looked at by many different groups across the world because of the concerns of sodium valproate associated with major congenital malformations and also minor congenital malformations. This not only applies to sodium valproate, but also applies to phenobarbital, phenytoin, and carbamazepine in large population-based studies as such. Topiramate was also identified as being associated with congenital malformations and should be avoided within children with girls and women who are likely to fall pregnant. So this is really, I think, an important consideration. Although it is a relatively rare event, it is disastrous when it does happen. And this is why these recommendations have come out and have really been the ones that have been been hotly debated, I have to say, around the world. And there is even now some debate, probably with no data at all at the moment, about whether sodium valproate might have effect on men who are in the reproductive age. But there's no evidence to suggest that it causes any problems at this stage. So just to emphasize that sodium valproate should not be prescribed in girls and women who want to become pregnant. And if they do become pregnant, then they should be advised to try and change to another alternative anti-seizure medication, preferably before they become pregnant, prior to conception. And this is best probably done in conjunction with a specialist in this context. The last specific recommendation for the 2023 was the recommendation that which interventions are effective in preventing epilepsy-related mortality, including sudden unexpected death of someone with epilepsy, SUDEP. The strength of the recommendation was conditional, and the evidence was very low that nocturnal supervision should be considered for prevention of SUDEP. And this is really based upon more common sense than anything else. It was a conditional recommendation with very low certainty evidence because it's been hard to find any data in this context. However, the consideration was given not only to the data within published studies in terms of making whether nocturnal supervision would make a difference or reduce SUDEP, but it was also based upon the values and health equity, equality, and non-discrimination, and human rights and socio-cultural acceptability and feasibility. It's a low-cost intervention that may have an effect, and certainly many of us will know of people who've died in their sleep with epilepsy, unbeknown. I think it was also important to point out that nocturnal supervision is defined as the presence of an individual of normal intelligence and at least 10 years old in the bedrooms, and these involve regular checks. And sometimes, for example, monitors, for example, like baby monitors, have been used in this context. And it's particularly important in people with convulsive seizures. The other thing that I think that was pointed out is that people with epilepsy with seizures that arise during sleep should avoid sleeping prone, because this will reduce the risk of sleep seizures. Although again, the evidence is poor for that. To finish off the talk, I just want to briefly mention the other recommendations which are in these updates, I think, which are relevant to epilepsy, and particularly the one on the anxiety disorders. And there, the psychological interventions based upon cognitive behavioral therapy should be offered to adults with generalized anxiety disorder or panic disorder. As you know, anxiety is often a comorbid condition associated with people with epilepsy, and this is particularly important. Stress management also should be considered, and there is a role for selective serotonin reuptake inhibitors, but in more severe cases, one needs to be a bit careful about the interaction with the anti-seizure medications. I think the other thing that was emphasized particularly was that the continuing importance of psychological range of treatments for mental, neurological, and substance abuse conditions, and that this was particularly for persons with psychosis or bipolar disorder, but also applies to other things, other conditions such as alcohol dependence, dementia, children and adolescents with neurodevelopmental disorders as well. And I think this is something that we, as neurologists particularly, are not very good at instigating and ensuring that our patients with epilepsy are given the opportunity for psychological and psychosocial intervention to improve these comorbid conditions in this context. The other briefly recommendations are digitally delivered psychological and psychosocial interventions are becoming more evident. There were recommendations of non-pharmacological interventions to improve outcomes of people with dementia, including physical exercise, CBT and cognitive stimulation therapy, and that there are also a list of antipsychotic medications which are included for treatment of psychosis and bipolar disorders. There are a number of negative recommendations. We've already alluded to the sodium valproate in women of childbearing age. The benzodiazepines are not recommended for the treatment of generalized anxiety on a long-term basis. They can be used for up to 7 days or in terms of severe distress, but not for longer than that. There is some indication that pharmacological intervention in children and adolescents with anxiety disorders may help, but again, I think that psychosocial and psychological intervention should be the first intervention that's recommended in this group of people, and that antidepressant medication should not be used in children under 12 years of age with depressive disorder. So in summary, the 2023 recommendations are that there's introduction of 2 drugs, which are now find them well on the WHO essential medicine list, levetiracetam and lamotrigine. Sodium valproate is not recommended in girls and women of childbearing age. There were updates on status epilepticus, generalized seizures, focal seizures, and SUDEP. And there was also the emphasis that psychological interventions are a cornerstone for the treatment and the management of people with mental, neurological, and substance abuse conditions, and that an anxiety module was also added. Thank you very much.
A big thanks, Charles. Thank you so much for the details that you have provided for these new recommendations within the updated mhGAP guidelines, so clearly elucidating not only the recommendations, but the evidence that they came from, as well as the implementation considerations. But also, I think what you've done is very succinctly summarized a very complicated process that WHO follows for this guideline development, and all the hours that you and other experts have given to this process, I think can't be emphasized enough. And I think you've kind of managed to describe this in a very simple, straightforward manner. So thanks for that. Let me now open the floor for questions from all of you. Both Charles and I would really like your active participation. And so please type your questions to Charles in the Q&A section that you see at the bottom of your screen. And he'll try and answer all of those. Just while you're doing that and while you're thinking of your questions, a few points that Charles made and I think are important. One is that with this new evidence now for newer anti-seizure medicines, which were not there in the previous mhGAP guidelines. So we have levetiracetam and lamotrigine now. As Charles said, it's one thing to have them in the guidelines, but then how does it become available in countries, and especially in low and middle income countries? These are not as reasonably priced or as cheaply priced as the other anti-seizure medicines, for example. So one step that has already been taken, in fact, in the short time since the guidelines have been published, is that now, based on the evidence that was collected for the guidelines, the WHO Model Essential Medicine list has included these two medicines in its list of essential medicines. So we have the Model Essential Medicine list, which then informs the country's national essential medicine lists and encourages them to kind of have these medicines within their essential medicines list, so that increases access to these medicines. Also in countries, these essential medicines list inform the standard treatment guidelines in the countries. So then, we have now these medicines which can be included in the standard treatment guidelines. So I think we've started the process, and hopefully, in the coming months and years, we'll see greater access to these medicines throughout. The other point that Charles made, I think, just to remind ourselves that these recommendations that Charles presented to you are the updates. The mhGAP recommendations for epilepsy, in fact, there are a list of 16 recommendations, 4 of which have been updated currently. So the other recommendations are still valid. And there's this new additional recommendation for SUDEP within this update. So don't forget that apart from all these new medicines that have now been recommended, like Charles said, there are the psychosocial treatments, there are the diagnostics that needs to be done, and all that makes for the epilepsy treatment and assessment. Charles, there is a question for you about for epilepsy for women who are pregnant or breastfeeding. How about perampanel for women with epilepsy who are pregnant and breastfeeding?
So I'm afraid I can't answer that because I've never used that drug myself. And also I don't know the literature on it. It would be, so I can't answer that question because I just don't have the information to give you an answer to that medication. I will certainly go and look it up now.
Yeah, no, and also I think when the evidence was reviewed for the mhGAP update, and they looked at evidence and systematic reviews for anti-seizure medicines and the effect on breastfeeding, in fact, they didn't find any additional evidence that they could include from what was already done in 2015. So the 2015 recommendation, in fact, is still valid. There are no new questions, so I'm just waiting for a few minutes to give people the chance to ask some. But meanwhile, maybe I can jump in, Charles, and I think with your vast experience, it's one thing, having these guidelines, but now I think what we want to see is what happens when, these guidelines are then taken into programs and implemented. So in fact, at WHO, what we do is we have derivative products that are developed so that they can be used by healthcare providers. So we have the mhGAP intervention guide that Charles has already mentioned, which has algorithms that healthcare providers can follow when they want to assess or manage people with mental, neurological, and substance use conditions, including epilepsy. There are treatment manuals, both for the trainers as well as for healthcare providers. So we have a trainer's manual as well as a training of healthcare providers manual. mhGAP will soon be on the WHO Academy, so it will be available as an e-learning course. And sometime later this year, that should be available. So there are these tools that we have, but I think it's people like Charles and people like who are working in countries, who are working on the ground, who actually implement these guidelines. And Charles, just from your experience of countries that you've done this in, what has been the success and what are the lessons we can learn?
So thank you, Neja. So we've implemented the mhGAP guidelines in two situations in Kenya. One is in a rural area in Kilifi County, which has got a population of about 1.2 million people. And we've done the entire county. So we've trained the primary healthcare workers, nurses, clinical officers in particular, and and a few doctors as well, medical officers as well, within the county to implement the mhGAP guidelines. We did not only for epilepsy, but we also did it for all the conditions within the mhGAP guidelines. And what we did it as a stepwise wedge design trial. And what we found is that there was an increase in knowledge about the conditions. There was an increase in the number of people that were being diagnosed with these various conditions as a result of the training. And also, what I think is particularly important was that there was a reduction in the stigma associated with these conditions given by the primary healthcare workers, because they often, people with neurological, mental health, mental disorders and substance abuse are often stigmatized by biomedical because they're thought it's their fault or whatever. We found that there was a reduction in the stigma associated with it. In Nairobi, which also Nairobi County, we set up again, looking at all of the interventions right across the county, including the informal settlements, but it also included other parts of the more established healthcare system. And again, we didn't do a step wedge design there, but what we did do is that we recorded the number of diagnoses that were being made by a dashboard, which was updated on a weekly basis. And with that, we're able to see that there's an increase in the number of people with diagnosed with psychosis, depression, dementia, and such like as a result of the training. So it definitely does make a difference. The things that we have found difficult are, first of all, that the training program was designed originally to be conducted in a week. We found that very difficult to do, and it normally takes 2 weeks in the context. The second thing is that there is quite an attrition in the knowledge. So it does need to be reinforced after a period of time, preferably 2 months or 3 months afterwards, and then again after that as well. So there needs to be continuous reinforcement of the use of the algorithms and the knowledge in that context. The other thing, and in that regard, what we think should happen is that this should be introduced, the mhGAP guidelines, because they're so simple, they're so clear, and they're so easy to follow, they should be introduced into the undergraduate training of nurses and of clinical officers, and even of medical doctors as well, because they do provide a very good platform in order to try and diagnose and manage these conditions. The other major problem that I think that I should point out to is that the changeover in staff. So you train everybody, And then suddenly the staff, you get such a high turnover of staff that you have to keep on training and keep on training. So it's an ongoing process that needs to be brought into within the system. But as I said, I think that we found that in the studies that we've conducted in Kenya in particular, and we've now introduced it both in certain areas in Tanzania and in Accra and Ghana, that these are effective. The mhGAP guidelines are very effective at improving the diagnosis and management of these conditions.
Thanks so much, Charles. What you've described, actually, I don't think it's unique to Kenya. In fact, the kind of challenges that you've described in terms of the attrition of knowledge and the need, I think the understanding that training is not enough. It's never enough. It needs to be followed by either retraining and supervision and support of for the healthcare providers. And I think that's the important role that specialists can play. When we're talking about task sharing with non-specialists, the specialists don't need to see everyone with epilepsy. The non-specialists can help with that, but they can be the ones to support and to train. The other point you made, I think, which was important, and I think that's really something that can change, the scenario and make it more long-lasting, is focusing not only on training people who are already in service, and using mhGAP for doctors and nurses, but using it for pre-service education. So when we are developing curricula, for example, for nurses or doctors who are then going to be setting out to work, having mhGAP or having mhGAP-like training within their curriculum, I think would be so important, so that, then if there's attrition or if people are moving out, or they already have that basic training. And in fact, the point you made about stigma, already having that training within their education also kind of takes care of the misconceptions they might have about epilepsy, or the stigma that they might have towards people with epilepsy. So I think that's a really important point. There is another question for you, Charles, about whether there is any action or project for physicians in private practice in trainings or fellowships that you're aware of. I presume that's mhGAP training.
Training, right. Well, first of all, I'm very pleased to hear about the WHO Academy. That would be wonderful, as such. There are, we did train people in private practice in Kilifi, for example, in particular, because they came and participated in it. And so there are opportunities, and I think that as the mhGAP guidelines get more widely accepted and more widely distributed, there'll be many more opportunities for training for all cadres of healthcare staff. We certainly don't want to restrict it. In Kenya, for example, about 40% of the healthcare staff, including the nurses and the clinical officers, work within the private practice in the private sector rather than the public sector. So just by focusing on the public sector, we'll be missing a lot of opportunity to train people who will be seeing people with these conditions.
I think, yeah, that's important. And that also relates to the next question here about whether someone is asked if they can take the mhGAP course online. It's not available yet. WHO works through ministries and through governments. So we try to embed the programs that we run within government systems so that they're sustainable. But there are like Charles said, numerous opportunities where partners take these products and take these resources and use them for capacity building. So I think look within your societies, look around and see what people are doing, and all these resources are available online. And if you need access to them, just let us know. If you can't access them, the links are provided here in the chat. I don't see any more questions. I'm just asking if there are any final questions before we conclude.
I would also point out, Naja, that the PDFs which come with the guidelines and the things are very useful. They're a very good way to start. So if you don't have a direct access to a course, You can download those from the WHO website, and they're very easy and simple to follow, so you can get a long way with it. I mean, I do think the training is very useful because it's quite a lot of role play. There's quite a lot of case scenarios and things like that. But the outlines that are provided in the PDFs are extremely useful.
Thanks, Charles, for that reminder. Yeah, so they're all available, the training manuals, the PDFs of the PowerPoint presentations, and these will be updated with the new recommendations also. They haven't been done so far, but within the course of this year, we will be updating these. I'm not sure I can see any more questions. Another question about, sorry?
About similar training programs in other countries. You probably know more about that than I do in Asia.
Yeah, like I said, there are programs, there are partners who are doing this, there are governments that are running these trainings. And if there is specific information that you would like, then do email, and we'll see what information we can share with you of how this might be done. Okay, I think we've reached the end of our time too. I can see that we've been here for an hour and all of you have stayed. So thank you very much. Thank you very much for your interest. Thank you very much for your participation. Thank you very much, Charles, for sharing your vast knowledge and experience with us, and for all your work with mhGAP. It's really, truly appreciated. And for me, really, the key takeaways from today's webinar have been that there is a large treatment gap in many parts of Africa, but there are resources available. mhGAP is one of them, and these can be used to increase capacity of non-specialists to deliver treatments for epilepsy. We now have new medicines which are safe and effective. There is this strong negative recommendation for use of valproate in women and girls of childbearing potential. And don't forget that with medicine, psychosocial treatments are very important for people with epilepsy. Before I close the webinar, I'm handing you back to Joe, but first to say a big thank you again to everyone, and for having me chair this incredibly interesting webinar, and especially today on International Epilepsy Day. Over to you, Joe, for announcements.
Thank you, Nirja. Just to say a huge thank you to both of you, Charles and Nirja, for giving such a wonderful and important presentation on International Epilepsy Day. This is a great kickoff to our year for the African Commission and the North African Eastern Mediterranean Commission for these collaborative webinars that we have. I couldn't thought of a better topic, and it's really, really related to such an important area. In line with some of the questions that have come up in the chat group about understanding projects and where we're going, I would like to encourage members on the group to be aware that the Global Health in Epilepsy project database is available through the International Against Epilepsy, and this provides a registry of existing epilepsy projects throughout Africa, the Eastern Mediterranean, as well as other regions, and it identifies information such as project location, institutional partners, project scope, funding sources, and volunteer needs. So the database is quick and easy to complete. And when you submit the information on your project, you will inform the understanding of efforts that are occurring throughout the world to narrow the epilepsy treatment gap. And this database will provide you with an opportunity to learn from others and to explore collaboration opportunities that might strengthen your own work as well as that of the sector. So furthermore, the database is going to allow people from different areas such as government, academia, nonprofit, and philanthropy to learn about the existing efforts that are being offered as a means to engage. So this is probably got the most impact and presence from the African region. It's really impressive, the projects that we're seeing, and you've heard about a number of them today with Charles and Nirja's discussions. So I want to encourage you to engage with that, and then to say that on the next slide that you're seeing coming up, you'll see the QR code, and if you scan this, you'll get your certificate. And there's also a link in the chat box where you can also access your certificate. So thank you, everybody, and take care and have a good evening, and well done. Bye-bye.